I'm Dr. John Michael Lau. I'm going to do a lecture on liver diseases as well as biliary tract diseases. So the learning outcomes for this topic is to visualize the gross microscopic changes and the clinical manifestations of liver injury, as well as to discuss the pathophysiology of the different forms of liver diseases. So first off, we have a case here of an old person, an old man, who was brought to the emergency room in a disoriented state. And physical examination reveals the man is alcoholic, with jaundice, yellowing of skin, with splenomegaly and ascites. The patient demonstrated coarse flapping tremor of hands, palmar erythema, and diffuse spider angiomata. The abdomen was distended and with dilated paraumbilical veins. The serum levels of ALT, AST, ALP, and bilirubin are all mildly elevated. Soon after admission, the patient vomits a large amount of blood. What is the most likely underlying cause of hematemesis in this patient? Anyone? Okay. So, what's your answer? Okay, the correct answer is cirrhosis. Okay, so the hematemesis is secondary to a ruptured esophageal varix or ruptured esophageal varices, secondary to portal hypertension, secondary to that is brought about by liver cirrhosis. Okay, so have you ever wondered, even though how complicated liver diseases become, they are still part of the continuum of liver injury? Okay, so this is what's good about liver diseases. All these diseases can be illustrated or demonstrated in just one picture, and that means these diseases are very much interrelated. So I'm going to show you one illustration linking these basic liver diseases in one picture. So the normal liver is the largest internal organ, and it weighs about more or less 2 kilos, and is located in the right upper quadrant. And the functions of the liver are varied. Okay, it's first of all, it produces bile for digestion. Okay, it also is a site of different metabolic processes, and the next slide will further mention the different functions of the liver. Okay, it is very vulnerable to insults, and although it can regenerate by hyperplasia, okay, there are some exceptions. Okay, the regeneration has some limitations also. Okay, there is a ceiling point. Okay, so these are the functions of the liver. Okay, so it can detoxify some toxic chemicals. It can also be the storage of different nutrients such as vitamins, minerals, and of course glucose, and produces most of the proteins needed by the body. Okay, that's why when there is a liver dysfunction, you have hypoalbuminemia. Okay, it produces bile, as we said before, and it is and this bile is used. It is a compound needed to digest fat and to absorb the vitamins A, D, E, and K, the fat-soluble vitamins. It's also responsible for blood clotting, by the production of blood clotting factors. Helps the body fight infection by removing bacteria from the blood. And it's also the site of several metabolic processes. Okay, so this is the normal picture or normal histological picture of the liver. Okay, the parts, the histological illustration, wherein what are the parts? You have here the central vein or the hepatic vein. Okay, branching outward radially, you have the hepatocytes. Okay, then you have the portal triad, the portal tracts. Okay, which is composed of the what? Since portal, first mentioned the portal vein, hepatic artery, and the bile duct. Okay, and depending on the on the basis of your how do you call this, basis of your basis of the lobule. Okay, you can have this. If your point of reference is the central vein, we call it the central lobule. Okay, if the point of reference is the portal triad, we call it the portal lobule. Okay, it can also have other point of reference, such as the portal asinus, which is composed of, you just connect the portal, the central vein, the portal triad, and to another central vein here, and another portal triad above. Okay, so that's the portal asinus. Anyway, that's just a review of your histology. And this is the portal triad, and what I want you to know here is that the farther the blood supply of the main blood supply of the liver is comes from the portal vein. Okay, it's a big vein. It supplies blood. Okay, although it's a vein, it supplies blood. Okay, it supplies the hepatocytes. Okay, and you have the secondary blood supply is a hepatic artery. The drainage is through your hepatic vein or the central vein. Okay, and the blood flow is going inwards. Okay, however, the blood flow is going inwards through your sinusoids. Okay, however, the production of bile is opposite this direction, opposite to that of the blood flow. Okay, so blood flow is going towards the central vein. Okay, the bile flow is going outward towards the bile duct. So from the bile canaliculi, draining to the bile duct, and it's stored in the gallbladder. So this is a very important picture. This is what I said before. It's the picture that summarizes everything that we need to know in this chapter. So you had the normal liver, and when you have mild exposure to injury, the liver becomes fatty. Okay, what we call steatosis. And further injury, you have hepatitis. That means the liver becomes inflamed. Okay, or you can also have from a normal liver with a severe exposure immediately to hepatitis. You can also have that one. And please take note, fatty change and hepatitis, okay, for the majority, okay, these changes are reversible. Okay, of course, with abstinence, or when you stop the exposure, when you stop the injurious agent. Okay, next, from hepatitis, okay, repeated attacks, you have cirrhosis, or what we call fibrosis. Okay, or the fatty change can immediately progress to cirrhosis. That can also happen. Cirrhosis, however, is not reversible. It is an irreversible change. And from a cirrhotic liver, you can have a mass developing from one nodule proceeding to carcinoma. Actually, there are other conflicting thoughts about the development of cancer, because other schools of thought say that from hepatitis it can still go straight to cancer. Okay, so the liver injury, the liver is injured by different injurious agent or stimuli, the most common of which is alcohol. Can have fatty diet. That is still questionable, because some doctors think that a fatty liver is secondary to the inherent production of cholesterol and triglycerides by the liver, not secondary to a fatty diet. Okay, so that's what we call hereditary hypercholesterolemia. Viruses such as hepatitis virus, drugs, okay, toxin or poison, ischemia. So even by just not supplying the liver with blood, you can injure the liver. Autoimmune diseases, bile itself can also, when there is a outflow of bile, you can have liver injury. Okay, sepsis, metabolic diseases such as diabetes. Okay, a fatty liver is a hepatic manifestation of diabetes. Bacterial infection, obstruction such as in gallstones, mutations. Obstruction, you can also have obstruction secondary to a thrombus. Okay, parasitic obstruction, mutations in cancer, and other injurious agents as well. So the common pattern in liver injury is that when the liver is, the hepatocytes, one hepatocyte is injured, it releases certain enzymes. Okay, this is what we learned in cell pathology, that during necrosis or apoptosis there is leakage of certain enzymes. Okay, and this is what we called before as endonucleases. Okay, so for example, in the heart, you have leakage of creatine kinase and troponins, bile duct, leakage of alkaline phosphatase, and liver, leakage of transaminases or aminotransferases. So let's go first to fatty liver. So I'm going to, in general, talk about the major entities in the continuum of liver injury. A fatty liver or steatosis is brought about by two factors. First is the deposition of lipid molecules such as triglycerides and cholesterol in one hepatocytes or in the hepatocytes. Okay, that's the oversupply of lipid molecules. Or secondly, you have the impaired transport of these lipid molecules towards outside of the hepatocyte. Okay, so a fatty change can be either, number one, alcoholic or non-alcoholic. So the mechanisms are displayed there. When it's alcoholic, it's secondary to a decrease in the NAD. Okay, so NAD, because the process is focused towards the metabolism of ethanol. So decreased depletion of NAD. Okay, And next is for the non-alcoholic fatty liver disease, it's secondary to insulin resistance. Okay, and when it's a drug or toxin injury, it is in injury in the mitochondria. Okay, fatty liver is reversible most of the time, but it can also be irreversible. So this is the histological picture. Okay, steatosis can also occur with minimal fibrosis. That is what we call chicken wire fence pattern. Steatohepatitis. Okay, so fatty change leading to hepatitis or inflammation leading to cirrhosis. And this is what we call as a burned out non-alcoholic steatohepatitis. So the non-alcoholic fatty liver disease is brought about by insulin resistance, okay, which results to triglyceride accumulation. So impaired fatty acid oxidation, increased synthesis, and decreased hepatic secretion. Okay, it is the most common cause of the incidental transaminase elevation. And this non-alcoholic fatty liver disease, it is at risk of proceeding to NASH, as we said before. Then cryptogenic cirrhosis. Cryptogenic means that although cirrhosis is there, the cause is unknown. Okay? So when the cause is unidentifiable, then the number one consideration should be non-alcoholic fatty liver disease. And again, it is associated with diabetes, metabolic syndrome. Second, hepatitis. Hepatitis means inflammation of the liver. So don't worry. Hepatitis, again, inflammation is again brought about by different causes. Okay, it can be reversible or irreversible. Okay, the predominant infiltrates here, don't worry, when you have hepatitis, whether acute or chronic hepatitis, the predominant infiltrates are mononuclear or lymphocytes, T lymphocytes. Okay, and when evaluating when if the hepatitis is acute or chronic, okay, you have it is based on the pattern, the severity, the chronicity, okay, and the sequelae is either the liver develops to failure or it can proceed to cirrhosis. So what are the major differences in acute and chronic hepatitis aside from the timeline? So number one, so for chronic hepatitis, you already see fibrosis, okay, portal fibrosis. Okay, for acute hepatitis, it's more on the cellular changes as well as the infiltrates. Okay, so with regards to hepatitis, the most common thing that comes to our mind is the viral hepatitis. Okay, so who are medtechs here, you already know this one. So just to summarize the table, okay, for this slide, I think the future slides I'll be talking about each hepatitis virus in detail. So for viral hepatitis, okay, you have hepatitis A, B, C, D, E. B, C, D, the route is either sexual or parenteral. Okay, can have intravenous drug abuse, okay, or through body fluids. For hepatitis A and E, these are fecal oral. Okay. So just take note that hepatitis C is the hepatitis that can undergo the most chronic cases. For hepatitis B, majority are acute. For hepatitis A and E, this can never go to chronic phase. That means these are self-limited. So the clinical outcomes of viral hepatitis, you can have any. So the patient may be asymptomatic. The patient may have acute manifestations such as with jaundice. Okay. Fulminant. So fulminant, that means that the hepatitis has become full blown. Okay, and it can result to death. Okay. Chronic. Okay, so chronic phase. Okay, after, so when we say chronic, it has undergone some acute phase. Okay, after a long time, the liver still survives and it's already in chronic state. And a carrier. Majority of carriers are transmitted through vertical transmission, but when there are also cases where it's carriers are made from horizontal transmission. Okay, especially when it has undergone the patient has undergone the immune tolerance phase. Okay, so immune how do you call this, the first two phases in chronic hepatitis. So we'll discuss that in ClinPath. First off, hepatitis A, it is a hepatitis virus that is obtained from food. Okay, fecal oral route. Okay, contaminated food and water. You can get it in the contaminated food that you eat in the restaurant or street food. Okay, barbecue. Okay, and the virus here, the injury is not toxic to hepatocytes. However, it's secondary to T-cell mediated damage or T-cell mediated damage of the infected hepatocytes. Okay, the solution is good hygiene and immunization. So looking at the graph, okay, this is the virus. Okay, you can have the buildup of antibodies doesn't have to wait when the fecal virus has gone down. Okay, so there will be a point where the antibodies will start to build up even when the virus is still there. Okay, for the hepatitis B virus or hepatitis B disease, it's transmitted mainly through sexual means. Okay, it can also be through infected needles and vertical transmission. Okay, replication of the virus inside the cell does not involve the DNA. However, when it's already in the cell, okay, not in the nucleus, okay, it inactivates the hepatocyte. It does not cause direct hepatocyte injury again, but through the T-cell damage, just like hepatitis A. Solution is through routine screening and vaccination. So, you know the Hep B vaccine, okay, 1612. Okay, so the particle that we're talking about in hepatitis virus, what's peculiar of hepatitis B virus is that it is composed of different particles. Okay, one virus has different parts. you have the surface antigen outside, the outside layer. Then you have the envelope antigen, that next layer. The one just outside the DNA, you have the core antigen. And the one inside is the hepatitis B DNA. By the way, hepatitis B is the only DNA hepatitis virus. In the slide, it presents us a ground glass appearance. Okay. So take note that the chronic cases of hepatitis B is only a minority. Okay. For most of the cases, this can resolve. Okay. And some percentage can undergo acute hepatitis. Okay, but minority is chronic. So just a minority. Majority is going to the asymptomatic or the acute phase. Shown in this slide is the rise and fall of certain hepatitis B markers in an acute phase, that is in the left, and at the chronic phase, that is in the right. Okay, so it illustrates in one slide where you see the viral markers such as here, the antigen. Okay, antigen is the HBs antigen, hepatitis B surface antigen, then the hepatitis B enveloped antigen. Then you also have the antibodies. Okay, antibodies, namely the antibody to the core. Okay, you have the total and the IgM. Okay, and the antibody to the HBe, as well as the antibody to the HBs. So it's a battle between the antigen and the antibody. Another curve here is the curve showing the serum transaminases, the SGPT. Okay, so take note, this is not the curve for HBs, rather it is a curve for the SGPT. So if you take note, if you observe here in the acute phase, when the antigen levels or the viral levels already get low, okay, or has already stopped, the serum transaminases also go down. Okay, so therefore upon recovery, there is no any more inflammation of the liver. Okay, at the same time it also gives us the timeline of the onset of the symptoms, okay, which is sometime after the occurrence of these antigen and the DNA. Okay, and a little bit after you have the onset of jaundice. Okay, so therefore in this case, hepatitis B really impairs liver function because of this jaundice as a result of retention of bilirubin. Okay, at the right side, you also see this is a chronic phase. You can identify that it's chronic because there is persistence of the HBs. Okay, you also have the persistence of the HBe that denotes infectivity. Okay, at the same time, since the virus is persistent, you also have persistence of transaminases or the SGPT. Okay, you also for the antibodies, you don't see any antibodies for the surface antigen because of the persistence of the surface antigen. Okay, so what's nice about the pattern of the rise and fall of hepatitis B antigens and the antibodies is that you don't see any antibody when there is still an antigen. So take note here, antigen, then you still have a window period where you don't see antigen or antibody to the surface antigen. Then much later you have the antibody to the surface antigen. So therefore you don't see an overlap between the antigen and the antibody. So this only applies in the hepatitis B. Okay. For details, we will discuss this in detail in ClinPath. Okay, so don't worry. So hepatitis C. So by the way, hepatitis B is the most common cause of hepatocellular cancer among Asians. However, hepatitis C is the most common cause of hepatocellular carcinoma in Caucasians or Western. Okay. Majority of hepatitis C cases are chronic. Okay. And the most common mode of transmission is through blood. Okay. Secondary is sexual. Okay. But majority is blood. And the antibodies, okay, do not confer effective immunity. In contrast to hepatitis B. So when you have antibody to that surface antigen, that means that the patient is already recovered. Okay. So, however, it is rarely fulminant. So next, hepatitis C, okay, again, majority is undergoes chronic phase. Minority is the acute. Again, this is a picture showing the rise and fall of the viral markers. Okay. Hepatitis D is special because it needs the infection of hepatitis B first. So therefore, the patient with a detected hepatitis D absolutely has been infected prior with hepatitis B. So it's very dependent on hepatitis B, either co-infection or super-infection. Co-infection, when the patient got both Hep B and Hep D at the same time. Super-infection is Hep D came after like several months, 3 to 4 months after Hep B infection. Okay. So next slide. Hepatitis E. It's a fecal oral. Okay. Contracted fecal orally. It's very common among travelers. And it is self-limited. However, among pregnant women, it is fatal. Other hepatitis as well, such as we know that in dengue fever, you also have a hepatic involvement. Okay, and these other diseases. And you also have autoimmune hepatitis. Which is which occurs together with autoimmune diseases. So next is cirrhosis. Okay, so we are done with steatosis. We mentioned about non-alcoholic. For the alcoholic fatty liver, we'll talk about it in drug or toxin-induced liver injury. Okay, much later. So we'll go back to alcoholic. We mentioned about hepatitis. Talked about viral hepatitis, cirrhosis. Next is cirrhosis. So in cirrhosis, you have fibrosis. Okay, fibrosis. So the fibrosis divides the liver into lobules or pseudolobules. Okay, again, it's multicausal, and the gross manifestation is you have a shrunken liver. Okay, cirrhosis encroaches down to the portal circulation, causing portal hypertension, and it is irreversible. So take note: cirrhosis, fibrosis, nodular appearance of the liver. Hepatocellular carcinoma is you have a tumor. Okay, you have malignant hepatocytes in the pseudolobules with periportal fibrosis. It's in situ or metastatic. In situ, that means that the tumor came from itself. Okay, or metastatic, that means the tumor did not originate in the liver, but it came from other sources. In metastatic, neoplasm. The most common neoplasm occurring in the liver is a metastasis. Metastasis from the colon, lung, and breast. Okay. Next is your primary benign, and the third one is the primary malignant. For primary malignancies, the most common is again hepatocellular carcinoma, followed by angiosarcoma and hepatoblastoma. So benign tumors are the following. You have cavernous hemangioma. This is a benign tumor of the endothelial. So endothelium. Okay. Vascular. So vascular channels. Okay. It's very prone to bleeding. Von Meinberg complex. It is a tumor derived from bile duct hamartomas. Focal nodular hyperplasia, it's very much similar to cirrhosis since you have hyperplastic nodules. Okay. And it's caused by incidental finding in women taking estrogen pills. Okay. You have estrogen pills. Another tumor is a hepatic adenoma. It is this one is the most common tumor that results from that intake of estrogen pills. Okay. And when the hepatic adenoma has been detected with a beta-catenin mutation, it is a pre-malignant lesion. Otherwise, it's not. Okay, that's hepatic adenoma. So pre-malignant, again, if it's a beta-catenin, hepatic adenoma, you have dysplastic nodules. Okay, cirrhosis secondary to the following. Okay. Although you have conflicting thoughts on cirrhosis as pre-malignant, because sometimes some doctors or scientists claim that cirrhosis can immediately arise from hepatitis. Okay. Next is cellular dysplasia. It can be a large cell cellular dysplasia or a small cell dysplasia. Okay. Small cell dysplasia is directly pre-malignant, whereas large cell dysplasia, these are not directly pre-malignant. Okay, but secondary to chronic injury. So you can read on those further. Okay. dysplastic nodules, take note that you have a nodule-in-nodule growth. Hepatocellular carcinoma, again, is multicausal. And the hypothesis, you have many. It's either from repeated inflammation and regeneration. You may have beta-catenin mutations, okay? Or actual defects in DNA repair, okay? Hepatocellular carcinoma can be unifocal, multifocal, diffusely infiltrative, or a combination. Can have discrete tumor masses, so one mass or one or two masses in the liver. You have vascular invasion, okay, or hematogenous invasion. Can be well differentiated, better differentiated, poorly differentiated, or you can have fibrolamellar CA. This is a special type of hepatocellular carcinoma wherein it does not arise from cirrhosis. So when it's well differentiated, you can still appreciate the hepatocytes with tumor cells. Okay, the treatment, it's either we resect or have a liver transplant, have chemotherapy. Sorafenib is a tyrosine kinase inhibitor, or hepatitis B vaccination. I think this is just adjunct, okay? So the symptoms can be a silent as hepatosplenomegaly, symptomatic cirrhosis, okay? The tumor marker here is AFP, alpha fetoprotein. Here, so we're done already, no? So from steatosis, hepatitis, cirrhosis, hepatocellular carcinoma. So let's go outside of that. We'll talk about drug or toxin induced liver injury. So the liver can be injured from direct toxicity by a certain chemical, or the conversion of that certain chemical to a more harmful toxin or more harmful version, or through immune mechanisms. Okay, potential toxins, you can name anything, either alcohol, medicines, okay? And it can cause cholestasis. Cholestasis is retention of bilirubin in the system. And when it manifests in the skin, it's called jaundice. So you have, first, the most common, again, toxin that we're talking about is alcohol. Okay? And what alcohol does is it induces cytochrome P450, which leads to the transformation of drugs to its toxic metabolites. Okay? So, not only does alcohol injure the liver, but other substances being taken in can also be transformed into more toxic forms. Okay? So this is the criteria for binge drinking, okay, or drinking too much. Okay, 5 or more drinks per occasion for men, 4 or more drinks per occasion for women. Okay, however, in 1 week, 15 or more, 8 or more for women. So, how they mention about drinks, okay, one standard drink is you have 1 12 ounce fluid ounce of regular beer. Okay, that's 5% alcohol. For malt liquor, 8 to 9 fluid ounce. Okay, that's 7%. For a table wine, 5 fluid ounce, that's 12%. And 1.5 fluid ounce shot of distilled spirits, okay, that's 40% alcohol. So even if you take a small amount, it's already high in alcohol. So what's so dangerous with alcohol? When it's taken in, okay, in the body, okay, it's transformed into different metabolites, causing different clinical manifestations. Okay, the metabolites that we're talking about is acetaldehyde and acetate. This is what we mentioned since before the NAD. Since the direction of the ethanol metabolism is towards the formation of acetate, acetaldehyde, okay, NAD is needed, okay, in the formation of acetaldehyde. It becomes depleted, and since it's depleted, the ethanol metabolism, okay, or the preferred metabolism is lipid synthesis. Okay, you can read on that. So these are the gross histologic manifestations of alcoholic hepatitis. So just take note, you have maluridenc bodies here. These are collapsed cytoplasmic structures, cytoskeletal structures, okay, that's caused by alcohol. So alcoholic cirrhosis, majority is micronodular. Next toxin that we'll talk about is aspirin. This aspirin is used to used to be the drug used to control fever among children before. However, aside from the side effect of bleeding, okay, it also causes liver injury, okay, causing a fatty liver or a fulminant hepatitis, even cerebral edema, causing coma on the baby. Treatment is to alkalinize the urine, okay, to excrete aspirin. So instead of aspirin, we use the acetaminophen. However, acetaminophen can also, in high doses, can also be harmful to the liver, causing hepatocellular necrosis. Okay, so very large doses, 4 grams a day. So that's 4,000, I'm sorry, this is 4 grams, 4,000 milligrams per day. The toxic metabolite here is the NAPK. What is impaired here when there is an injury secondary to a toxin or a drug, okay, toxin-induced liver injury, is the detoxification process of the liver. You have impaired conjugation, sulfation, and glucuronidation. What is affected here in detoxification, okay, secondary to metabolic, secondary to acetaminophen, is sorry. Okay. Zone 3, which is the farthest from the hepatic triad, okay, and the nearest to the central vein or the hepatic vein is the most sensitive to ischemia, okay, and metabolic toxins. Zone 1, however, is the most sensitive zone to ingested toxins, okay, since it is the nearest to the blood supply. So this is a very important table wherein you see the etiologic agent as well as the pattern of injury and the morphologic findings in the liver. Okay, good to take note that for example, in alcohol you see miliary bodies. Okay, what else? In intake of abuse of intake of oral contraceptives, it results to Budd-Chiari syndrome. Okay, you also have sinusoidal dilatation. Okay, Budd-Chiari syndrome is thrombosis in the portal outflow of the liver. Okay, hepatic adenoma is also a result of the abuse of oral contraceptives. Angiosarcoma is secondary to, most especially to, the prolonged exposure of vinyl chloride, okay, polyvinyl chloride, PVC. Okay, so next. Okay, so here we have liver diseases that is secondary to retention of bilirubin. Okay, we call it cholestatic liver diseases. You can have a cholestatic liver disease from primary hepatocellular dysfunction, okay, or bile duct injury. Okay, so you have retention of bilirubin or retention of bile, okay, secondary to a dysfunction in the liver or a bile duct injury. So under primary hepatocellular dysfunction, you have neonatal cholestasis, cholestasis of sepsis, and drug toxin-induced cholestasis. So how do we explain neonatal cholestasis? So of course, you see it in the neonates, and retention of bilirubin, particularly conjugated bilirubin, is secondary to inborn problem or a how do you call this, a inborn problem of the liver. Okay, so the liver is not able to transport the conjugated bilirubin, thus the retention of the bilirubin. Okay, so take note that this is not physiologic jaundice. Okay, so because physiologic jaundice is retention of indirect bilirubin. Okay, it is due to hemolysis. Okay, hemolysis of the red blood cells. Okay, but it is transient, and it can be solved or it can be treated by sunlight exposure or exposure to UV. Okay, next you have cholestasis of sepsis. So even infection, okay, can also cause ischemia in the liver and septic shock. Okay, thus retention of the bilirubin. And two types, you have canalicular and ductular. Ductular is the more dangerous one. Drug toxin-induced cholestasis is a consequence of hepatitis. Okay, and you have two kinds. You have bland and the cholestatic hepatitis. So you have the without inflammation of the liver and with inflammation of the liver. And it is secondary to the following toxins, drugs and toxins. Okay. So comparing both, you have retention of bile or bilirubin. Okay. Then here the black portions, so this is canalicular and this is ductular. The black portion indicate that there is endotoxemia, so retention of the toxin. So bile duct injuries, so we're still in cholestatic liver diseases secondary to bile duct injuries. It may be secondary to mechanical obstruction, okay, due to a stone, for example, in cholelithiasis, cholecystitis, okay, that cholangitis, hepatocellular carcinoma, and that's a tumor. So mechanical obstruction secondary to a tumor and cholangiocarcinoma. Or you may also have autoimmune diseases. Okay, so two examples here, you have primary biliary cirrhosis and primary sclerosing cholangitis. The destruction of the bile ducts here for both cases are secondary to autoimmune, so they just destroy by themselves. Okay, and what's how do you, these are very much alike. Okay, so how do you differentiate? Both are highly associated with other autoimmune diseases. How do you differentiate? The primary biliary cirrhosis is very common among females. Primary sclerosing cholangitis is very common among males. Okay, so if you take note of the, if you observe the name, there is a for biliary cirrhosis, there is a bias towards liver cirrhosis. For primary sclerosing cholangitis, there is a bias towards inflammation of the bile ducts. Okay, but more or less the manifestation or the characteristics are very much similar. Okay, for primary biliary cirrhosis, what is affected are intrahepatic bile ducts. For primary sclerosing cholangitis, what are affected are the extrahepatic. Okay, you still see intrahepatic, but more in the extrahepatic. Okay, what else? So the next slide. Primary sclerosing cholangitis, take note that there's a characteristic beading appearance. Okay, so and the final sequelae, or the final sequelae, is what we see, what is known as the biliary intraepithelial neoplasia. Primary sclerosing cholangitis in its severe form is pre-malignant in the form of biliary intraepithelial neoplasia. Okay, so this is a table comparing primary biliary cirrhosis and primary sclerosing cholangitis. So if you take note, if you observe that the associated conditions here are different. Okay, so majority Sjögren's syndrome. For here you have inflammatory bowel diseases, particularly ulcerative colitis. Serology, majority is anti-mitochondrial antibody positive. For primary sclerosing cholangitis, majority is you have anti-neutrophilic cytoplasmic antibody positive. Okay, when we say florid duct lesion, that pertains to primary biliary cirrhosis. Okay, and the rest you can read on. So this is the onion skinning and tombstone scar in a PSC. Okay, compare it to PBC, you have florid duct lesion. Okay, So we're done with cholestatic liver diseases. Let's go to inherited metabolic diseases. So we mentioned that the liver is a site of metabolic processes. Okay, and here there the diseases that are exemplified here are diseases that retain certain element or certain minerals, okay, that are toxic to the liver. Okay, so because it is retained, it causes fibrosis and hepatitis and cirrhosis on the liver. Okay, so take note, you have hemochromatosis, Wilson's disease, and alpha antitrypsin deficiency. So what's the problem here in hemochromatosis is there is retention of or accumulation of iron. Okay? And it's secondary to a defective HFE gene, hereditary iron gene, also producing a defective hepcidin. This hepcidin, I'll show it in the next slide. It's a molecule that is responsible for iron regulation. Okay? So hemochromatosis can also be acquired secondary to excessive blood transfusion. It's also called bronze diabetes because it leads to, number one, again, cirrhosis. If it's accumulated in the pancreas, it causes diabetes mellitus and bronze skin pigmentation. Okay? The treatment is phlebotomy. Okay? So you have to get rid of the blood that is very high in iron. Wilson's disease. Okay, so I'll show you the pathophysiology of hemochromatosis here. So I'm going to explain this model. Okay, so normally in the liver, iron the red one is iron. Okay, so iron absorption is regulated by this molecule, the green one, the hepcidin, which is produced by the HFE. So this is the HFE is the gene, the protein or the protein molecules are the hepcidin. Okay, it regulates the absorption of iron. Okay, that's why not all iron are go into the bloodstream. Okay, whereas in hemochromatosis, you have a problematic HFE gene, thus a problematic hepcidin. You have low production of hepcidin, thus you have the absorption of iron is uncontrolled. So you have high levels of iron in the blood, and that is very toxic, causing cirrhosis on the liver. So anything, if you notice any over retention of any chemical, poison, or any injury, okay, will in the long run causes cirrhosis on the liver. So let's go back. So the next picture is on the next metabolic disease that we will discuss is Wilson's disease. It is excessive accumulation or retention of copper. Okay, and the gene responsible is the ATP7B gene. Okay, and what's the problem here is that the copper cannot be passed to apoceruloplasmin in the liver and thus cannot be excreted into the bile. Okay, so if you observe, you have retention of course of the copper in the liver. Okay, that's number one. Also, please take note that there is retention of copper in the cornea, causing Kaiser-Fleischer ring. Okay, this is very much mistaken, especially in the old patient, as a what you call this, Arcus sinalis, okay? But Arcus sinalis is blue. What's the cause of Arcus sinalis? This is retention of cholesterol in the cornea, in the rim of in the cornea of an old patient. But this one is brown. Okay. You also have an effect on the central nervous system, mental retardation, okay, and other organs as well. So okay. So next is the alpha antitrypsin deficiency. So you're familiar with antitrypsin, okay? Antitrypsin is an enzyme, okay, that combats trypsin, okay? And trypsin, by the way, is the one responsible for emphysema, pulmonary emphysema. So we need antitrypsin to combat the effect of trypsin. Okay, so deficiency of antitrypsin because of the mutant antitrypsin. Okay, so there is again retention of antitrypsin. Okay, let's see, retention of antitrypsin in the liver. Okay, so therefore there is no production of antitrypsin that will coat the lungs, okay, to combat emphysema. So therefore you have the liver is already exhausted with antitrypsin. Okay, the antitrypsin cannot go out, causing cirrhosis again in the liver. So if you observe in this case, elastase, this is a trypsin. Okay, so you also observe that elastase also activates. It's also activated by cigarette smoking. Okay, so these are the conditions associated with alpha antitrypsin deficiency. Emphysema, pulmonary emphysema, is just one. Okay. Okay, so we're done with metabolic disorders. Did I miss anything? Let's go back to the previous slide. Okay, so retained mutant. Okay, so this is just last one. Retained mutant antitrypsin gene in the liver causes cholestasis, hepatitis, cirrhosis, pulmonary disease. Okay, emphysema, and the treatment is liver transplant. So we're done with inherited metabolic liver diseases. Now we're going to circulatory disorders. Okay, so this pertains to obstruction. Okay, in the blood flow in the liver. So impaired inflow. Okay, so what are the blood vessels affected? You have portal vein and the hepatic artery. Okay, obstruction is does not only pertain to a thrombus obstruction, but you can also have obstruction secondary to parasitic obstruction. Okay, or obstruction secondary to the cirrhosis itself. Okay, impaired intrahepatic blood supply. Okay, you also have impaired outflow. Okay, so inflow intrahepatic and outflow. Okay, so take note, just don't be daunted by the name. You have portal vein, hepatic artery. This one is sinusoids. This one you have hepatic vein, and also the sinusoids. Okay, with the clinical manifestations, these are very much similar. Okay. So in the inflow, when the portal vein is obstructed, this really affects much greater, because it is the major blood supply in the liver. Okay, for the hepatic artery, there's not much effect. Okay, here, cirrhosis is the most common cause of portal blood flow obstruction. Okay, you can also have obstruction secondary to congestion. This is a systemic circulatory compromise, is just another phrase for chronic passive congestion. Okay, so we have a case of chronic passive congestion in the laboratory, and you also have obstruction secondary to sickle cell disease. Okay, DIC, and fatal intra-abdominal hemorrhage. For the outflow obstruction, you can have a thrombus in the hepatic vein, or also a obstruction in the sinusoids. So hepatic vein and the sinusoids. For the hepatic vein, the thrombus formation is secondary to the following. Okay, please take note: oral contraceptives. Okay, mechanical obstruction secondary to parasitic infection or tumor. For sinusoidal obstruction or vein occlusive disease, this is deals more on obstruction secondary to intake of toxins, and this one is more fatal than Busch-Chiari syndrome. Okay, you have take note: Busch-T. Okay, Busch or Bush? Busch-T. Okay, chemotherapy also. So the one in the left is Busch-Chiari, the one on the right is sinusoidal obstruction. The one on the left is more particular with thrombosis. The one in the right is due to toxins and other inflammatory and infectious liver diseases as well. Okay, so you have liver abscesses. We have examples of liver abscesses in the laboratory. And it can be secondary to an infection, which is the most common, vascular. Okay, so direct route, and you also have a penetrating injury. Okay, trauma. Granulomatous disease. One thing that will really come in your mind when you see a granuloma is TB. Okay, so the most common example here is TB of the liver. Okay, you also have other diseases that cause granuloma formation as well. Okay, so we're done with the examples of liver diseases. Okay, we mentioned about in metabolic diseases, drug toxin induced liver injury. We mentioned about obstruction, okay, in the blood flow, circulatory disorders. Okay, so whatever they are, okay, these are the next thing that we'll discuss is the usual pattern of clinical manifestation of liver injury, okay, or what we call as clinical syndromes. So how do we spot if a person has a liver injury? So this picture basically summarizes everything. Okay, so for you have this one. This picture pertains to the severe form of liver injury, particularly in cirrhosis, okay, and or liver failure. So effects of portal hypertension, you have varices, you have splenomegaly, caput medusae, okay. For hepatic failure, you have hepatic encephalopathy, gynecomastia, secondary to retention of estrogen, okay, asterisk 6, asterisk 6, okay, also secondary to ammonia encephalopathy, bleeding tendencies due to the poor production of clotting factors. So we'll talk about them one by one. Okay, so for the clinical syndromes, you have jaundice and cholestasis, cirrhosis, portal hypertension, portosystemic shunt, hepatic failure, and hepatic encephalopathy. Number one, jaundice is the clinical manifestation of, or it's the yellowing of the skin and the sclerae, okay, due to retention of bilirubin. But when the retention of bilirubin becomes systemic, it is what we call as cholestasis. Okay, the skin manifestation and the sclerae manifestation is what we call as jaundice. It results from the following. Number one, very common, you have RBC hemolysis. There's no liver impairment, okay, with RBC hemolysis. Okay. Second is the impaired bile flow due to liver disease. Okay, so this pertains to impaired transport of conjugated bilirubin. Okay, next is impaired bile flow secondary to biliary obstruction. Okay, so when there is a when there is a gallstone or cholelithiasis or cholecystitis, it can also cause jaundice. Okay, in ClinPath we will discuss about bilirubin metabolism, but basically this figure just shows us that bilirubin comes from red blood cells, okay, and becomes conjugated in the liver. Why does it have to be conjugated? Because it needs to be soluble. Okay, but some certain bacteria in the gut deconjugate again. Okay, the normal level of bilirubin is less than 2, okay, or is less than 2 milligram per dl. But if it becomes increased to as high as 20, then it is very dangerous because it can cross the blood-brain barrier. That condition is called kernicterus. So these are the main causes of jaundice: hemolytic anemia, hepatitis, bile outflow obstruction secondary to a gallstone or a tumor, physiologic jaundice of the newborn, sepsis. Okay, we also have inborn errors of metabolism. Okay, this one is seen among neonates. Okay, you have a deficient glucuronidase. Okay, glucuronidase, by the way, is the enzyme that conjugates bilirubin. Okay, so good to take note, you have retention of unconjugated hyperbilirubinemia. When it's mild, it's what we call as Gilbert syndrome. When it's severe, it's called Crigler-Neyhar. And when there is a deficient transport protein causing retention of conjugated hyperbilirubinemia. Okay, that is what we call a Rotor syndrome. When it's mild, when it's severe, it's Dubin-Johnson. Okay, so we mentioned about cirrhosis a while ago. Okay, so this is just a review of what we mentioned. This is secondary to excessive fibrosis or scarring, causing the formation of nodules. Okay, most common, more often than not, it's a non-alcoholic steatohepatitis. Okay, that causes cryptogenic cirrhosis. Cryptogenic cirrhosis, again, is cirrhosis that is of unknown cause. So if the causative agent is unidentified, then most probably that is caused by a non-alcoholic steatohepatitis. And it can lead to hepatic failure, portal hypertension, okay, because the fibrosis can encroach into the portal circulation, or you also have hepatocellular carcinoma. Okay, so there you have different routes. Okay, so how do you explain cirrhosis? So the problem with cirrhosis is that there is activation of the stellate cells. Stellate cells, no? These are the cells that produce collagen, okay, in the space of this. Okay, so you have activated stellate cells. So why are the stellate cells activated? It's because of it's triggered by the injury or the toxic agent. Okay, fibrosis is the capability or the capability of the liver to heal itself. Okay, but the healing also compromises the hepatocytes. So here, how are the hepatocytes compromised? You have number one, loss of microvilli. Okay, you also have the loss of fenestration from the endothelium or the sinusoids. So thus you have hepatocytes that become atrophic or become apoptotic. Okay, so next is portal hypertension as a result of cirrhosis. Most common cause is cirrhosis, but you also have non-cirrhotic portal hypertension secondary to obstruction by parasites, okay, or fatty change, massive fatty change. Okay, so what happens is that in portal hypertension you have intrahepatic shunting, okay, from the portal circulation, okay, that reduces clearance of the bacterial DNA and causes splanchnic arterial vasodilation. And this explains the number one manifestation is ascites. So you have splanchnic vasodilation. And secondarily, ascites can also be caused by hypoalbuminemia. So there is number one, increased hydrostatic pressure, but you also have decreased oncotic pressure. That is caused by hypoalbuminemia. The other manifestations are splenomegaly, and the last three is a result of because of the intense portal hypertension. There's formation of collateral circulation, collateral channels. Okay, thus you have esophageal varices, hemorrhoids, and the caput medusae. Okay, so this is a acidic tummy, acidic abdomen, and the superficial veins that appear are what we call as caput medusae because it looks like the head of Medusa. Okay. Next, so you also have portosystemic shunt. So from the portal system, portal circulation, there is a shunt towards a systemic. So as seen in the varices, okay, esophageal varices, so you also see the caput medusae and the hemorrhoids, so gut-butt caput, splenomegaly. Okay, we also see because of the preferred blood supply towards the splanchnic, okay, splanchnic area, there is a severe reduction of renal blood flow causing renal failure. This is what we call hepatorenal syndrome. Okay, whereas in the lungs, in the kidney, you have renal shutdown. In the lungs, you have pulmonary congestion, okay, causing portopulmonary hypertension and hepatopulmonary syndrome. Okay, you also have anti-trypsin deficiency or alpha antitrypsin deficiency causing emphysema. And this is the web of the effects of portal hypertension. Okay. Hepatic failure. So hepatic failure is the effect on the liver. Okay, it is the it pertains more on it's failure of the liver. Okay, that pertains more on the incapability of the liver to metabolize different substances, okay, such as proteins, such as bilirubin, okay, and there's a fine line between decompensation, wherein the liver can still try to compensate, okay, or failure, wherein the liver cannot anymore do its function. Okay, and this can be tested or this can be evaluated by the following tests. Okay, this is what we call the liver function tests. These are liver function tests, and however, the first one is the test that test hepatocyte integrity, which are the enzymes, which are the hepatic enzymes. Okay, biliary excretory function. Okay, one of which is an enzyme in the biliary epithelium. You also see bilirubin. Okay, but the third one is the real liver function test, which tests on the function of the hepatocyte. That this pertains to albumin formation, the production of clotting factors, and other hepatic function tests as well. So what are the signs of dysfunction or this decompensation? So you have jaundice, you have hypoalbuminemia, okay, hyperammonemia, hypoglycemia, pulmonary erythema, okay, spider angiomas, hypogonadism, gynecomastia, weight loss, and muscle wasting. Whereas the signs of hepatic failure are the following. You have coagulopathy, secondary to a impaired production of clotting factors, hepatic encephalopathy, secondary to the retention of ammonia, okay, and we also mentioned already hepatorenal syndrome, that is renal shutdown, portopulmonary hypertension, and hepatopulmonary syndrome. Okay, So this is, we mentioned already before, hepatic encephalopathy, wherein you have the retention of ammonia, which is a byproduct of protein metabolism in the blood that crosses the blood-brain barrier. Okay, and these are the manifestations. Okay. So again, the signs of hepatic dysfunction, and just read on. So I have tabulated the signs and symptoms and the pathologic or physiologic mechanisms. Okay. So we've already discussed a lot about liver diseases. So it's time for us to reflect, why is it important to take care of our liver? And how? How do you take care of your liver? And how important are history and PE, as well as the appropriate and timely use of laboratory tests in diagnosing and assessing liver diseases? Because we have to admit that we need the support and the help, assistance of these laboratory tests. That includes diagnostics, radiologic findings on the liver, okay, to help us aid in our history and physical exam. Okay, so that's it for liver diseases. So let's go to biliary tract diseases. So we're done with liver diseases. Let's go to biliary tract. So this biliary tract includes the gallbladder. Also see the bile ducts. Okay. So that's the schedule again. And the learning outcome basically is just to visualize the gross, microscopic, and the clinical manifestations of these diseases, and more importantly, to discuss the pathophysiology. Okay, so we have a case of a 36-year-old woman who has become increasingly icteric or yellow, okay, or jaundiced for 1 month. And she has several bouts of colicky abdominal pain for 3 years. Okay, so when it pertains to jaundice, we have 2 organs that we have to consider. Okay, more importantly, the liver and the biliary system. Okay, the gallbladder, that includes the gallbladder. On physical examination, the patient is jaundiced with scleral icterus, and BMI is 32. That is obese. Okay, and tenderness in the right upper quadrant, and the liver span, however, is still normal. The liver biopsy is obtained, and the microscopic examination shows us a biliary proliferation. So if you've read previously about biliary proliferation, and we know what condition we are leading to. Okay, and intracanalicular bile stasis. Okay, so actually I have some diseases in mind. Okay, but no inflammation or hepatocyte necrosis. Okay, so what are the possible diseases here? Number 1, since the patient, you have several risk factors. In this case, a patient is female, patient is fat. Okay, patient has colicky mid-abdominal pain, colicky. Colicky, that means there is a spasm. Okay, so we're talking about cholelithiasis. Okay, since there is a finding of biliary proliferation, then the cholelithiasis causing cholecystitis, okay, causing what? Biliary proliferation is secondary biliary cirrhosis. Okay, the question is, what is most likely increased enzyme in the patient's serum? So since we're talking about gallbladder, it's alkaline phosphatase. Okay, So the biliary tract diseases that we'll talk about encompass the following: the gallbladder, the biliary tract, and we also talk about tumors. So normal anatomy lang, no? So we have the bile ducts, hepatic ducts, left and right hepatic duct merging into the common hepatic duct. The common hepatic duct and the cystic duct, which comes from the gallbladder, merge into the common bile duct, no? Which is the bile supply of in the duodenum of the large intestine. Okay. So these are the most common gallbladder diseases. Number one, you have cholelithiasis. And we have two types of cholelithiasis, means gallstones. Okay? It is secondary to the bile formation, excessive bile formation. You have two routes. Either you have excessive supply of bile, okay, or you have decrease output, decrease emptying of bile. Okay, so there. So you have two types, cholesterol stones and the pigment stones. Cholesterol is composed of, again, cholesterol. It's very common among Caucasians. Okay. For pigment stone, it is very common among Asians. Radiolucent, cholesterol. Radio-opaque, pigment. But more often than not, these, what you can find are the mixed stones, a mix of cholesterol and pigment. Okay, so this is what I mentioned before. Gallstone formation, you have secondary to excess cholesterol, excess bilirubin, decreased bile salts that will dissolve the cholesterol and bilirubin, and decrease gallbladder emptying. The risk factors, take note. Just remember, fat, female 40, and fecund or fertile. Okay? OCP, estrogen pills, are very highly thrombotic, at the same time causes saturation of bile. Okay? So what are the signs and symptoms? Majority, it's asymptomatic, but when it's symptomatic, you have excruciating, spasmodic, what we call colicky, right upper quadrant pain. Okay? And the complications are the following. You have formation of pus or empyema, perforation, okay, fistulas, okay. You have the inflammation of the biliary tree, or what we call as the cholecystitis, and even pancreatitis. So the one on the left is cholesterol stone, the one on the right is pigment stone. Next is cholecystitis. It is the inflammation of the gallbladder, and the most common cause is gallstone. Okay. So, you have two types. You have the acute and chronic. So, for the acute cholecystitis, you have an enlarged tense gallbladder, okay, with fibrinous serosa. So, it's a bile-filled lumen with fibrin, with blood and pus or pus. Neutrophilic, there's a neutrophilic infiltration. Majority is you have a stone. The stone irritates the mucosal lining. That's why you have inflammation of the gallbladder. When it's a calculus or secondary to there's no stone formation, Okay, it can be secondary to number one. You have infection. Please take note. You have bacterial infection. You also have sepsis, again, bacterial infection, severe burns, okay, dehydration, okay, from severe trauma, motor vehicular accident, okay, and the manifestation here is, aside from the right upper quadrant pain, is that there is a radiation of the pain towards the right shoulder, okay, plus fever. Chronic, so when there is a chronic retention of gallstones or other causes of acute cholecystitis, then that's chronic cholecystitis, and you have lymphocytic infiltration. And what's so painful here is that the attacks are recurrent. Okay? You have intolerance to fatty food. So complication, you have superinfection, bacterial superinfection, and the other conditions as well. Okay. So let's go to extrahepatic biliary tract diseases. So we're going out of the gallbladder. When we say cholelithiasis, this is simply the retention of stones or gallstones in the biliary tract. Okay. Next is cholangitis. So when the bile duct is inflamed, then that is cholangitis. Okay, here you also there's a triad of cholangitis. It's called the Charcot's triad. It's composed of the right upper quadrant pain, jaundice, and fever. Okay, that's Charcot's triad. Aside from stones, okay, another complication is bacterial infection and parasitic infections. Another example of extrahepatic biliary tract diseases are, number one, secondary biliary cirrhosis. This one is most commonly caused by gallstones. Okay, so it's prolonged obstruction of the extrahepatic biliary tract causing liver damage. So next, you have biliary atresia. This is a inborn, okay, this a neonatal disease wherein there is a failure or absence, destruction or absence of all the part of the extrahepatic bile duct. Okay, thus resulting to neonatal cholestasis, acolic stools, and death. And the treatment is liver transplant. For tumors, you have only two. Okay, you have the gallbladder carcinoma and cholangiocarcinoma. A tumor arising from the gallbladder, okay, that's gallbladder carcinoma. This is very uncommon, okay, but it is the most frequent malignant tumor of the biliary tract. Okay, you have the risk factors, gallstones, okay, and infections, because what happens here is there is chronic irritation of the gallbladder epithelium. Okay, and we have two types. If the tumor is inside, that is infiltrating, okay, which is more common. If the tumor is outside, that occurs in the serosal part, then that is exophytic. For cholangiocarcinoma, what you have to remember is that, again, there is chronic irritation of the biliary epithelium, okay, and it is seen in old patients, okay. And what is the cause of the chronic irritation is that are the following. You have primary sclerosing cholangitis. Remember before we mentioned about the primary sclerosing cholangitis, the intraepithelial biliary neoplasia, okay, which is pre-malignant. So the malignant form here is the cholangiocarcinoma. Second is the fibrocystic disease of the biliary tract. Okay, if you're familiar with Caroli syndrome or Caroli disease, this is the other term. Okay, you can read on Caroli disease, okay, by yourself. Next is parasitic infections by Clonorchis and Opistorchis. Okay. You have two forms. You have the two forms are intrahepatic and extrahepatic. Metastases are lymphatic, okay, and it can go to the lungs, the bones, and the adjacent nearby structures, okay. So this is gallbladder cancer, exophytic type. This is intrahepatic cholangiocarcinoma, okay, and showing the glands, no, glands with tumor cells. And topics to read further are the following. We have hepatic disease associated with pregnancy. What I can remember is the fatty liver in pregnancy. Number 2, hepatic complications of organ or bone marrow transplantation. So when there is an organ transplanted, take a look, check on the liver if there is an increase in the liver enzymes, okay. Aside from rejection of the organ, okay, so we can also identify some complications. Next is congenital anomalies of the biliary tract. You can have agenesis, so failure of the formation of the biliary tract. You also have the Phrygian cap, okay. You have a fold in the gallbladder epithelium. You also have polycystic formation in the biliary epithelium. That is what we call the Caroli disease. When it involves the liver already, then that's called Caroli syndrome. Number 4, you have iatrogenic injury to the biliary tree. So any operations iatrogenic, means that's doctor caused and or surgeon caused, and any operations in the intestinal area or the nearby structures can cause accidental perforations of the biliary tree, okay, especially the gallbladder. So thank you very much and have a great day.